Thank you so much for having me. I'm going to be talking with you this evening about my why. So that's why I went into research, my research journey, and why I'm still here. My aspirations to become a physician and a women's health researcher really began with strong female role models that I had both growing up and into my medical training. This is Graham Biddy. She was known as Biddy for her short stature. She lived to 110 years old, 1886 to 1995. She was the matriarch of our family, and I was really lucky to get to know her. When I was a little bit older, after she died, I started hearing stories about how she had had struggles with her reproductive health. She had had 4 children. It was the early 1900s. She decided to seek a divorce from her longtime husband in order to be able to make her own choices about whether or not to have more children. This is my maternal grandmother, Graham Jane, who is Biddy's second child. She instilled in me a lifelong passion for education and for learning. She was a librarian. She went back to school after having children to get an undergraduate degree and a master's degree. She chose to have a family and a career, which was relatively rare at that time. She was a true librarian all through her life and really into the later years, even in the few years before she died. She would keep up to date on my career. She would send me articles from the newspaper about stroke, about women's health. She was like my personal librarian, helping me with my literature searches. And finally, my mom, who's a lifelong feminist, she spent the 1970s protesting, doing women's studies in college, and then volunteering at domestic violence shelters, which I ended up doing as well. These three women together really inspired me to pursue higher education and also to pursue a career in which I would advance understanding of women's health. So fast forward to medical school, I decided that a career in medicine was going to be how I contribute to women's health. I chose emergency medicine, partially because it was exciting, but really because I wanted to be part of the safety net that was present when people came to us for help any time of the day. I had a problem though. I wasn't sure how I was going to fit my women's health interests into a career in emergency medicine. I had started a women's health research career in undergrad and medical school when I did work in basic science labs. But then I started interviewing for residency and got lots of blank stares from program directors. I had a few questions. Why aren't you going into OBGYN? Not that I don't love OBGYN. I have a lot of OBGYN friends, but it wasn't for me. I was going to be an emergency medicine doctor. I ended up finding the perfect match at Brown University, where they were starting a new division of sex and gender-based medicine. I spent 4 years of residency, not only learning to become a doctor, but learning how to study gender disparities across the disease spectrum, cardiovascular disease, sepsis. I learned that there are sex differences in how diseases present, the efficacy of therapeutics, the accuracy of diagnostics, outcomes. And fast forward some more, how did I end up in stroke? So as I was looking at sex and gender-based differences in various diseases, stroke came up frequently. I saw patients in the ED time and time again that had waited hours, even days, before they sought care for their stroke symptoms. And I started feeling very frustrated that I couldn't fix their symptoms. I couldn't improve their outcomes after they left my hands because they didn't get the reperfusion therapy that they needed. And I learned other really interesting things about sex and gender differences in stroke. I learned that women have non-focal symptoms like pain, headache, and confusion, in addition to the focal symptoms that they have. I learned that women face longer delays to the initial CAT scan. And I learned that women are less likely to get standard of care therapies, such as reperfusion, anticoagulation, and statins for high cholesterol. So I dug deeper. I did more clinical research, quantitative and qualitative studies looking into some of these topics. But I very quickly realized that in order to make a bigger impact on women's health at the population level, I was going to need to take a step back to preventing the stroke in the first place. So I went back to school. Consistent with my family history, with all the inspiration that I had gotten from my female role models, I went back to school, gained an advanced degree in clinical and translational research, and then ended up doing a Ph.D. in epidemiology. My husband won't let me do any more degrees. I'm done. But that's where I landed, and the rest is history. What I've been doing for the last several years is really looking at the mechanisms by which stroke risk changes over the life course for women and why it increases so dramatically during peri and postmenopause. We're looking at things like sex-specific risk factors, migraine, endogenous sex hormones, and using lots of cool data, genomics, metabolomics, and other high-dimensional types of data to better understand the mechanism. But it hasn't been all roses. There have been some challenges. I've had lots of opportunities, and I'm very grateful, but I've also faced challenges. So rejections. I think this is part or an expected part of an academic career, but I have to keep this in mind, and I often counsel mentees about rejection and how to get through it. My particular example that I give people, this is not the only one. I submitted a K-23 3 times before being successful on the 4th. So that's perseverance. The second area of challenge, which I'm going to highlight here, is the chronic underfunding of women's health research. For decades, women have been underrepresented in medical research. This is one of the reasons I was inspired to go into women's health research. I was lucky enough to be part of a consensus study from the National Academy of Medicine. We sat in a room and we came up with recommendations for solutions to this problem at the NIH level. So giving recommendations to the NIH about how to better fund women's health. Interestingly, this was released in October 2024, which was terrible timing. I'm concerned that these recommendations will never be implemented. And then finally, a loss of trust in science and in scientists. But the challenges make the work even more important for me. I continue to be inspired by my patients, by my colleagues, by my mentees to keep doing this work. So the work of taking care of patients, the work of writing papers, writing grants, and now getting to train the next generation of scientists to be excited about women's health. And I anticipate that these challenges are not going anywhere. They may get worse. I think that my dedication to women's health is going to continue to be tested. But the patients are still here. They're still in the ED. The women are still here. They still need my help, and I'm here for it.